This is Kate Fern, and this is my speech on racial disparities of the United States healthcare system with a focus on the tough and transformative choices that have to be made by these two sides. And so basically the debate here is whether or not certain statistics such as higher mortality rates and lower success rates in certain healthcare settings and operations in people of color are due to either systematic racism in those healthcare settings, or if they are due more to other demographics such as access to Medicaid and just general areas of residence. So going back to my speech over the last few weeks, minority groups have lower healthcare insurance. This is just a statistical fact, and we can back that fact up with a study done by Rodolfo Bulantu in 2002. He researched in the research agenda a basic understanding of racial and ethnic differences in health in late life, and this offered us the statistics and the facts that African Americans, Hispanics, and some Asian populations, when compared with their white counterparts, appear to have lower levels of health insurance coverage, with Hispanics facing even greater barriers than any other group. And people of African and Hispanic descent are less likely to have insurance coverage overall from a private employer, whether that is directly or through a spouse, and more likely to have public health insurance coverage. There are many limitations to Medicaid and Medicare alone, and they can create certain economic challenges for people of color because Medicare does not necessarily cover some of these medical needs, which can definitely contribute to these statistics that we see. There was another study done by Holster and Klein in 2018, and this statistic published that the mortality rates from heart disease, breast cancer, and stroke decreased from 1990 to 2005. However, the gap between African Americans and white mortality rates actually increased. So this is just another way to back up those statistics there that we see beforehand. And the other side of this debate here is whether or not these statistics are due to systematic racism in the United States healthcare system. So there are many racial disparities that we see, and they need to be understood within the context of racial inequalities in these social institutions. There was a study done by Williams and Rucker in 2004, and this is from a research study titled Understanding and Addressing Racial Disparities in Healthcare. And basically, this just told us that there are more striking and disconcerting growing number of studies that find racial differences in the receipt of major therapeutic procedures for a broad range of conditions, even after adjusting for insurance status and severity of disease. Therefore, this just tells us that there have definitely been studies to prove that, as well as factoring in some of these other factors, that those death rates are still substantially different. And Williams and Rucker also tell us that race was and is a social category that captures differential access to power and desirable resources in society throughout the history of the United States. Non-dominant racial groups have, either by law or custom, received inferior treatment in major societal institutions. Medical care is no exception. So that's just another thing to think about. And there are several things that can be done about these racial insensitivities in healthcare, and also can kind of take away those demographic barriers that we see. And in terms of avoiding that systematic racism in a healthcare setting, basically we need to start avoiding implicit bias. And this can be a very difficult thing to do, just because an implicit bias basically just means that you aren't necessarily aware of the level of bias that you may have. And there was a study done by Kiara Bridges, who is a reporter with a human rights activism group. she offers a statement that physicians, just like the rest of the American people, have an implicit bias, which means they have views about racial minorities of which they are not consciously aware, views that lead them to make unintentional and ultimately harmful judgments about people of color. So again, this just means that you don't necessarily have to be outwardly racist and offensive, but sometimes you just have these instincts in the back of your head that kind of offer those offensive terminologies and those offensive things. So there's also very many ways that we can tackle the demographic side of this argument, and two of those ways is to battle the language barriers that we can see when it comes to people of color and potentially white physicians. And then we can also just implement stronger training in med school, in college, in high school, in any sort of setting where you would be able to pick up on these implicit biases. Just kind of taking those away from the initial source is a great way to go. So in terms of the language barriers, there was a study published in 2002, which is an article titled "Minority Americans Lag Behind Whites on Nearly Every Measure of Healthcare Quality." And their main focus point was about these different language barriers. And basically it stated that minority Americans are much more likely to experience difficulty communicating, and Hispanics are twice as likely as their white counterparts, and it offers a 33% to 16% difference about having a difficulty communicating with their doctors. And there are many people, especially people of color, who could start walking away from healthcare because they don't necessarily understand it or because they can't afford it, which also ties us back into that Medicare. The argument that we face here is whether or not racial disparities in the United States healthcare system are due to systematic racism or a more demographic-based approach. While both of these problems are very instinctively present, they also offer some possibilities towards a brighter future and some aspects that we can move towards those.